Hello guys, and welcome to another video. And in today's video I want to show you insights into the virtual MSK fellowship program, and you can watch one live session, like one Q&A live session here as a recording on YouTube, and I have another one over on my free platform on School. So if you like this one here on YouTube, go over to my free MSK School community where you can make an account for free. It's free to join. There are a couple of lectures there, and you can also find more or like another one of these live Q&A sessions there in the classroom. So go over there too. You find the link in the description down below. But back to this video. So have a look at this discussion. So it's a 1 hour session. People can bring their own cases from their own institutions and hospitals, and then they can ask questions about their own cases, and we discuss these cases like you would if you were a fellow, and I would be the attending, and then we discuss these cases. Now, if you want to learn more about the fellowship, go over to my homepage. It's www.agten.org. You can also find the link in the description down below or somewhere here in this video, and then you can go there. You can watch a free training video as well where I explain a little bit about the problems that people face with MSK radiology. You can also see a lot of testimonials from people who did the program with me, and then you can essentially, if you are interested and really want to do this and really take your skill to the next level by learning and getting all these feedbacks and the calibration down, then just arrange a call with me and we can discuss how the fellowship might help in your particular situation, and just to see whether it's actually a good idea for you to do that or not. And when you sign up, then I'll see you on the other side. Okay, so that's basically all for that. So make sure you give the video a like and also share it with your colleagues if you think this is great content. Let me know in the comments also if you like such case discussions more. I can certainly do a couple of these sessions throughout the year where I can have you people join or watch, or maybe we can also live stream sometimes these kind of like sessions. So I'm thinking about stuff like that. So give me comments if you like this kind of like content. It's totally not scripted, and I don't know everything either. So sometimes I'm also coming to the limits of my knowledge and skill, but it's still good to discuss these cases, and then we can also sometimes resolve these cases as a group together. So I think it's a really good way of learning MSK radiology, and it's probably the best one, to be honest. Okay, so let's jump right in, and I wish you have have fun, and see you next time. Bye bye. Try whether that's actually working. I'm not sure. Anyway, so let's see. For list of cases. So Vanina, let's start with your first case. Yes, Vanina, please.
This is a 57-year-old male. He was a little bit non-cooperative with the questions. He refers no trauma, but I'm seeing some edema and a cortical defect in the radial tuberosity. So I was wondering if it maybe is a partial avulsion of the biceps tendon.
Mm-hmm. And what did he do? Was there a sudden event or no trauma?
He refers nothing, that he
So,
has pain, increasing pains several months ago, that started several months ago. So that's what's weird for me.
okay.
But
Yes, okay. Yeah, so when there was no trauma history, obviously, then we are looking at more something degenerative. So we have to believe him, especially if you ask. And you can see there's quite a narrow distance here between the radial tuberosity and some bony irregularities, and the tendon, which kind of like goes in and inserts at a broader site here, is likely going to be chronically impinged or frictioned upon with some peritendinous edema. And we can also use or to see whether there's any partial tears. And we can go up here, we can kind of like appreciate the two parts of the long end of the biceps tendon here, these two bits. And when we go down, we can see that this one is going down all the way. And I think for the second one here, we can say this is at least partially torn, maybe even like a full thickness there. So I would probably go with basically the whole tendon is partially torn, and this one we always have to check whether it is the long or the short bit. So the more distally inserting one would be the short head. This is something like I always have to look up. Try to have a mnemonic, but my mnemonic never really works. So we go into biceps, distal, long head. I actually have a video about this, but Ratsource has actually a good diagram for this, so we can just quickly check. So you can see the short one has the more distal insertion, so that's how you can remember this, but I'll still have to always look for this. Anyway, so we have these bit here. So we have the brachialis tendon, then we have the two heads here, and the more, well, quite difficult to say which one would be more distal, but it could be that this one would be the more distal one, and then we have this area where I think here the long head in that particular case then would be at least partially torn. So let's see if we have any other sequences that we can use. You repeated this one, so we can go up here again, and maybe we put 2 by 2, so we can have this one next to it, and then we can follow it down. So we've got the 2 bits, and this is now radial, so we can briefly compare. This is just the opposite, so the more radial one would be the one who inserts more proximal, which would be the long one. So that makes sense that this is the long head of the biceps tendon, or the distal part of the long head, and it's torn, at least high grade, or if not complete. And the short head, which is this bit, goes down, shows some peritendinitis here, and most likely some mechanical issue in this area where there is quite a close proximity to this. So that's what I would go for. Depending on how much detail you want to give, you can just go with a partial tear of the distal biceps tendon with peritendinitis, and then bone marrow edema, irregularities here. And if you want to be a bit more specific, you can make this distinction between the two heads at its distal insertion, which I would probably do because the clinicians might, well, depending on who you're talking to, but some might not be aware of this. And then we can also check the other bits, lacertus fibrosus and all of that stuff, and you would measure retraction, because there is a bit of a retraction, which we can kind of like appreciate maybe here. But you're right, he moved a little bit. We don't see it nicely on these ones, but on these ones I would probably go with maybe from here, which would be from this one to this one. It's arguable, so maybe from here it's tapering out, so just maybe 1 centimeter, not even, just a couple of millimeters. That's why maybe even tiny bits of the short head, of the long head also still going through, maybe, so it's just a partial tear of this, or high grade partial tear of the second slip of the tendon, which would be here the red one coming down. All right. And then, yeah, you can have this also degenerative. It doesn't always have to be a distinct acute injury or trauma.
Okay, thank you, Chris.
Okay, thanks, Vanina. So let's go to the list. So we have Anatoly's case now. Anatoly, please.
Hi, Chris. Hi, guys. Thank you. This case is about 33-year-old male patient with an unspecific right hip pain for about 2 months, and there is no history known of some trauma, some acute trauma accident. And my question would be about small fluid collection around the head-neck junction. May it be a periosteal hematoma? Because I'm hesitating about this diagnosis, because he is not something like young adult, and it's really strange position for this pathology.
So what it is essentially is a joint effusion. So it's all just joint effusion. So if you do arthrograms, for example, you then see that the joint capsule insertion can go as medially or as laterally rather than this. And I think the one that's a bit confusing is this structure here, creating like a septum, but that's the medial neck plica. So it's a plica within the hip joint, which goes down here, and it's just kind of like a plica in the knee, if you will. So even that bit and that bit, it's still just joint effusion on both sides. So it's a medial neck plica and, well, hip. And so I think that's a high quality illustration here. So kind of like a synovial fold in the joint. And in your case, it's a particular nice one. So basically it's the same here. This is now an arthrographic study. It's the same here. So this is this medial neck plica. It's basically a synovial fold here, different articles. I think this is, they have nice illustrations, but maybe not specifically for this, but for the, no, this is the another plica up there in the hip, and then this one here. Jenny Bencardino, neck or neck plica, not even, I don't think it's actually a medial neck plica, but it's just a neck plica. So that's the term that we can use. I'm gonna post this in chat so we can have a look at this article. But let's find the original article. Or you can actually download it. So I'm just gonna put this here in chat and then we can have a look there. Okay, so it's all joint effusion. Now the question is, why does this person has this joint effusion on one side with no trauma? We don't see any high-grade, cartilage defects or anything. So we have to think also of something like inflammatory effusion or para-infectious or any other reasons, non-specific hip pain for 2 months, no trauma. Okay, so yeah, I would certainly recommend further testing, either like rheumatological review, where there's some para-infectious stuff. Maybe they have to do an aspiration. It's a bit of edema also, unless there would be any if he's very active or something, but normally they don't really just get effusions for 2 months. That would be not normal. Sacroiliac joints, they look fine, and the pubic symphysis and the other hip is as well. So labrum is not looking great, but then we've got a bit of edema in the more posterior aspect here of the hip. So yeah, something rheumatological would certainly be in the differential. There's still some cartilage loss though, and the labrum is also torn. It's certainly degenerated, but you can see the cartilage here should be the same thickness as here, and there is cartilage thinning nearly down to the bone, not quite, but still, and there is certainly advanced degeneration and certainly also tearing into the labrum substance here as well. But yeah, I would still be surprised that this would be a pure degenerative thing for that long time. And so this was, just to be sure, this was not an arthrogram or anything. Yeah, no, so we can see this is the T1 and there's no contrast in there. Okay.
And speaking about edema in the posterior aspects of the acetabulum and of the femoral head, maybe there is some form of impingement or no?
It's not a very typical location for these kind of like impingements. What do we have here? A bit of it. No, this is the nerve just coming down. Yeah, so this is not typical for the mechanical impingement types, unless he is doing some strange extreme hip motion, martial arts, yoga, or I don't know, anything like this. If they have this extreme hip motion, then it might become a mechanical issue. But the cartilage loss and labrum damage is more in the anterosuperior quadrant. There's also a bit of edema back here at the acetabulum. And so there was no incident like trauma or anything like you said, right? Okay, so then, yeah, I mean, they need to rule out any inflammatory disease. And then if that's not, then maybe he has some history of funny movements or something where this would become a mechanical issue. It's quite congruent. We don't see any cam deformity or anything like that. Maybe that's just the acetabular coverage is not super great, but I don't see anything else. What do we have else here? So you can see also a little bit of periostal reaction here. So maybe there is a mechanical issue here, but this is not very typical. So I would certainly extend the history also into any like funny sports or positions where he would incur a mechanical problem at that location.
And does he also have some mild cam deformity?
Well, do you have any
or
very
no?
thin? We can use this one. Oblique. Just this is even possible if you don't have 3D images, just to give a rough idea. You want to just fold it in to the neck axis and then we turn here. We can check any of these. Well, let me just go here. So this would be, I mean, there is not like a, here, if you look at this image now, the head neck junction, it might fall off as quickly as it could be. So there might be a contribution a little bit. Like if you were to measure alpha angle, etc., it would be increased at that location. Sometimes also the sagittal will give you a little bit of an idea. So it looks like there is just a tick too much bone here at that location, but it's not like a major thing. Even here you get the idea that there is just a tick too much bone. So there will be a mild cam situation, but a lot of people have that, and that alone might not necessarily explain much. But you can also see that the acetabulum is quite shallow, and if we go for the femoral head, we can measure this angle too. So we would have to have both hips, obviously. So roughly here. Oh no, not like this. So maybe from here down. Normally I don't measure this, but the coverage lateral center edge angle, as on we can measure on MRI, seems to be on the lower side. So there's kind of like this plastic situation here, which might have contributed to this degeneration in this hip. So I think it would be interesting to see if there is any history of funny sports or anything like that. And then the second thing, like in joint effusion, either aspirate it, just rheumatological review, see whether there is any para-infectious thing going on, or maybe other joints are also involved. But yeah, so the peripheral reaction back here, the bone marrow edema on both sides of the joint, might indicate something more like mechanical. I don't see anything for osteosteoma or some funny other lesion. That normally is only on one side of the joint, so I would not expect this. And I think he was 40 something, so it's not in the best age group for that differential either. Yeah, so it's here is a little like a cam here. It's not nicely harmonic, and that's explaining part of this bit here. So basically a big head and then small acetabulum, like this plastic here. Okay.
Thanks a lot.
Yes. All right. Thank you. Thank you very much for the case. So let's go to the next. Where's my list? Q&A. There we are. So Nilum, let's go to your case now.
Okay, it's a shoulder arthrogram. It's a 21-year-old male with shoulder pain for about 4 months. No inciting traumatic event or injury. He just he lifts a lot in the gym, and he also works as a waiter. And so my question was about the superior and middle glenohumeral ligaments, and if they're torn, and also the proximal biceps tendon if that's torn. Last week I also had a case where the MGHL was torn on the arthrogram, and I feel like it's torn again on another patient.
Yeah,
it seems odd because I don't normally see this. So I'm just wondering what's going on.
Yeah, I remember the other case. Yeah, so sometimes it can look like more like frayed, and if you look here in this case, so this was an arthrogram, and we can see the needle tract roughly coming down here. And depending on, if they have a little bit more external rotation, I think sometimes the MGHL just comes into way of the needle. So I think sometimes we see stuff just injected close or in or through the MGHL. So we can see in the T1, it looks quite high in its signal. So maybe part of it might be actually that. And we don't have any, so this is a young person, right? And there was no trauma. So I would be maybe in this particular case a bit more bit reluctant to actually be too aggressive. I would maybe call just fraying or something like that. And then differential would include iatrogenic injection or something to the arthrogram. We don't have the actual arthrographic image, but yeah, anyways. So we can also see there's a bit of a wavy appearance. This can just be positional. And then this is the MGHL, so basically coming down here. It's the other one here, coracohumeral ligament, and the anterior bands of the IGHL are further down. Okay. Yeah, so I would maybe just go with a little bit of fraying or something like that, and differential would include some maybe injection of it. Let me just double check if we are actually looking at the right structure here. Yeah, so because that back here, that's just kind of like in between this dirty, I just need to window this a bit different, this dirty stuff in between either parts of the fraying or a little bit of a localized synovitis, although we would not be understanding yet why there is synovitis here in the first place. Okay, that was I think that's all. So MGHL, I would put this, so there was just pain. I would just bury this in the report, not bring it up in the conclusion in this particular case.
Okay,
and what was the second structure? I'm sorry, I forgot.
Oh yeah, so the superior glenohumeral ligament, like on the sagittal T1, it looked a little strange, and then the proximal biceps tendon is that.
Yeah. Okay. Yeah. So SGHL. So I normally try to find it here at this location where we then get the sling of the pulley. So here I think we can see this bit here. Oh, sorry, this one. It's not going down yet. This is the biceps tendon, and then here this one here, this one, and then on this bit. So the question is, where is the biceps tendon on this particular image? So it looks like there might be a gap, so we don't see it coming down. And on this image, we have the biceps tendon. Most of it will be already biceps tendon as it has to go down. So I would have expected the pulley SHL bit to come down here. So in this particular case, I would mention this. So the SHL laterally looks torn. I would just probably put it in like this. I don't think there is like a nice ligament anywhere that would be holding this in place. But this is just one of the studies. So we go to the other so that we don't fall for any like partial volumes or any funny other business. So we go here. We see the same thing essentially on this one. So it's just a question whether on this particular image, this line would qualify for the SHL, but I don't think so. I think for me, that's already then too far out. And then we have the T2 fat set. We can also check on this one. Just need to make sure we're not too bright. Yes, and since it's an arthrogram, I think we should nicely see this. In most of the cases, we can see it. The biceps tendon is not subluxed though, and when we go to the axials, we don't. Yes, we do have axials. So it's centered. There's no subluxation, at least not yet, and the subscapularis tendon comes over and inserts nicely. Yeah, I would describe this as a small like defect in the SHL here. It's very early on potentially, whereas the biceps tendon in the interarticular segment is just flat, but it has a low signal, and the origin of the biceps tendon, we can go either here or here. So we can follow it up into the joint. It's circling around the head, going into the anchor, inserting there. And also I would not call a tear here. So I think I would just no slap and the biceps tendon would be okay. And then distally in the sulcus, also I would write this as normal.
I actually thought there was a posterior labral tear. It didn't look so good. Posterior supralateral
Yeah, this one
tear.
here, yeah, so there's some fraying. That's right, going further down. Here it's okay. Here, this is the fold, synovial fold, labrum here, and then it starts to kind of like fray out a little bit. I don't see a distinct tear on this particular image, but let's see if we have any other sequences we can look at. We have the T2 and the T1. Let's have a look at the T1 as well here. So based on the coronal images, I would not give a slap tear as a distinct tear. On this here, it's not super obvious, so I would not see anything on these coronals, but on the axials, at this location where we often though have a little bit of signal change due to the orientation of the labrum, but still it's too blurry, it's too hazy. It's not just the signal, it's also the morphology. So I think fraying at this supraposterior labrum, I think that's a good point, yes. And yeah, so then some down here, some extravasation, and it goes also anteriorly. We don't really nicely see the anterior band of the IHL coming over, maybe here. Okay, so this one is the anterior band here. This one, it's okay. Then this axillary portion. So it's just probably just iatrogenic extravasation anteriorly. And we can also see it here. Anterior band here is fine. And this can sometimes happen. And also you can see the contrast going down here. So I think it's just a narrow, or maybe how much volume did you inject? It goes all different places. It goes down here, it goes down here, it goes down here.
I know. I gave maybe 14 milliliters.
Yeah, okay. Maybe it just has a
is,
smaller joint capsule than normal, but we don't see any thickening or anything like that in terms of a adhesive capsulitis or anything like that. So it's maybe just a small joint. Was it a large person or a small person, or do we have any?
No, he was a pretty big guy.
Big guy, okay. Yeah.
Yeah. Can you look at the supraspinatus tendon, both on the T2 and T1s? Because there's this little bright signal, but it's also bright on T1, which makes me think it's contrast, but I don't see a tear. So I'm like so confused. Or I don't know if that's in the supraspinatus tendon.
Yeah, but where in the tendon? This one?
Right there. Yeah.
Okay. Yeah, so we can see that. So, and let's see the axials. Where are we? This one. and this is far from the injection path. So there is, yeah, it's funny though. I think this is clearly contrast. I agree. So I would also say this is contrast going places where it should not. And then let's go here on the sagittal, where we can see that. That's this bit. So it's not a vessel, but we don't see any distinct tear. So the only thing we could maybe start seeing, if you want, is kind of like a little bit of irregularity here at this undersurface. So maybe there's kind of like an interstitial thing that's going through here. That's funny. And on the T2, that's this bit here. So we can see it on all sequences. So it's real. And on the T1 here, on this, yeah, and even here. So there has to be some form of an articular-sided tear that goes with a tiny fissure through the substance. That's how I would rate this at this point. There's also a funny cyst back here, but that's just fat. Okay, this is just fat. So maybe some intramuscular lipoma or something. Is it also fat? This is T1, T1. And it's also fatty. Yeah, it's also fatty. So tiny lipoma does not matter. But yeah, the other bit was actually contrast. And yeah, so there is some form of a tiny fissure going through. In the bursa, I didn't see any contrast though. And so the question is, does this start to come out? So is there like a small perforation in a way where there is communication from the joint through a tiny defect into the tendon substance? But it looks like the tendon surface, if I would have to draw it, might just go over it, and it's just on a very thin AP diameter. So I would measure this bit. I would describe this certainly, and would suspect a tiny fissure or tear where contrast leaks from an articular-sided bursal tear through the tendon substance close under the surface here. I think we have to probably acknowledge that, and also even down in the conclusion. I don't see how that how we could explain this any other way. It's a good pickup. Very tiny bit here. We can also see it here on the T2. Yes, Leonard, please.
Regarding the suspected SGHL lesion, do you think it's an indication for arthroscopy or
that
just
by itself? No, I don't think so at this point. That alone, they would have to have like a very high clinical suspicion also for this, and we have, depends on how the symptoms are, etc. But this is just like we don't see it completely going through, but we don't have any like subluxation. But if the patient has clinical instability and all of that stuff, I'm not sure whether they decide to just go in and do something. But there's no slap tear either, so I'm not sure whether this per se would qualify for surgery. But we would have to ask one of the surgeons on the school, like from the shoulder surgeon, to see what he thinks, if it's just this finding alone, whether to do something about it. I would probably not want to have surgery just based on this, especially if there's not much more damage back here, because what can they do? They don't really fix this. I've never seen like a primary slab repair. Normally they do not pulley repair. They either do a labral repair back here, because that's what mostly will be the painful thing, because the biceps tendon is just constantly pulling on it, or they do a tenodesis or tenotomy. And he's a young guy, so we just don't want to do more damage than what might actually be there.
Okay, thanks.
Hey, Chris.
Mm-hmm.
So the posterior superior labrum is frayed. So that means at one time it was torn, right?
No,
Otherwise, how would you get
I think it's just kind of like a. It's not. It doesn't have to be torn and then frayed. So it can just be normal. Then it starts to fray, and then maybe at some point it will tear. If that makes sense. So it's kind of like so for me, I use the term fraying more if something is like very like blurry. So if I would have to draw a normal labrum, that would be something like this, and then the frayed labrum would be just kind of like, I mean, it's technically microscopic tears at the surface level, but you don't have any like deep tears or extensions or something like that, where you have to have a tear that goes all the way through like this, or any other like funny ways. That's kind of like for me how I use the term fraying, which this location sometimes, and this depends a little bit on the technique, can be hard on the axial, because as we said, like on the sagittal here, it looks quite okay. Although here we also have the partial volume effects all the time, because it's just this silly corner where we just kind of like have difficulties to see. But I don't see any contrast going in. I don't see any fluid going in. It's just the signal, and the morphology looks a bit maybe swollen, maybe like a bit blurry. That's why I think fraying is a good term at that location. So maybe also part of these bits here.
Okay, that makes sense. Thank you.
Yes, you're welcome. Okay, good. Any other questions for this case? No? Okay, then let's go to the list. Amal, let's go to your case.
She is a 36 years old female patient complaining of chronic anterior knee pain. The orthopedic asked about chondromalacia patella and its grading. Is it a grade 2 chondromalacia patella or not? And I see also a complex tear in posterior horn medial meniscus, a horizontal and radial component with meniscal extrusion.
Yes, looks like we probably have to work with the T2 on this scanner. So we can go here laterally, medially, maybe this one. So we can see there's a bit of extrusion here of the medial meniscus, and I don't see like a obvious frank tear at the posterior root. So let's see if we can see something else. On which sequence did you see that?
BD sagittal, I think.
PD sagittal, okay. Here. So there's also some ganglion cyst here at the base, and I think here you can see here the shape has kind of like an indentation. So I guess there is a horizontal tear as far as we can say here in this quality here, and then horizontal tear, and then some ganglion cyst coming out, some extrusion. I don't see like the root seems to go down here. I don't see a tear in terms of a radial tear at the root avulsion or anything like that. And the radial tear, let's see if we can get an idea. So I think this is now kind of like hard to call. It's just one image, so bone, and in between is what we see. So when we assume the meniscus would have a nice contour, and it should have quite a nice average signal all the way around. So we can see there are some changes here, so in this area here, which I don't necessarily appreciate much.
Can you see sagittal T2?
Okay,
please?
so on this one here, this is now the stir sequence. We can see the horizontal tear here also. And then we have this ganglion cyst here, the extrusion. And which one, on which sequence? Sagittal?
T2.
Sagittal T2. This was coronal ACL. PD. Now they are... okay, so we got some... this is the PD here. Oh yes, so this one is a good one, yes. Yeah, horizontal tear like we suspected, and then also down here. And then the parameniscal ganglion cyst here. Still, I would go with root still going down to the bone, and then here the extrusion. So this area here has also this tear that we saw here on the axils, and I can also kind of like see how the contour is irregular. So I think we can agree on a complex tear. There might even be part of the meniscus lifted up here a little bit, so this is also not the normal shape and morphology of the meniscus. So I would go with a complex tear, primarily horizontal in the posterior horn, and then becoming more complex at the extruded body or something along that line. I think that's what I would go in terms of meniscus, with a lot of posterior medial joint capsule irritation and these parameniscal ganglion cysts. So you can see there's a lot of edema here at this posterior medial joint capsule. Okay, and the other bit was the cartilage of the patella. Yeah, so we can see the thickness here is okay on the, which one is this? This is the lateral side, and then at the medial facet we can see thinning of the cartilage. So this would be the expected thickness, and then there is an area where we have low thickness also at the patellar apex going all the way up here. So thinning of the retropatellar cartilage here, and it's probably more than 50%, but it's not going down to the bone. Any other stir images? It's the only one. We don't see any obvious bone marrow edema. So more than 50% on that area. That's what I would write in my report. So deep cartilage thinning on the medial facet of the patella and the patellar apex, up to or more over 50% of cartilage with no subchondral system bone marrow edema. That would be roughly my dictation for this. And the cartilage in the trochlea femoris here is a bit harder to assess because of the orientation again. So I'd like to see that on a sagittal. I think sometimes it's just easier to see that on a sagittal, and here, at least sometimes you can see it nicely at this transition zone, how the cartilage kind of like behaves, but we don't see any. Just the T1 is not helpful. This one. It looks there is also some irregularity to the cartilage. Requires a bit of getting used to the signal, but you can see it's a bit edgy. It has kind of like bumps, and it's not just a nice smooth surface. And also at this location, I would expect that maybe there is some thinning on the lateral facet of the trochlea, whereas here the cartilage looks a bit thicker, knowing that this is a oblique cut through the cartilage and not a 90-degree section because of the transition into the femoral condyles. Yeah, so here. Okay, Amal, is that okay, or did I answer the question?
Yeah, it's okay, but the clinician asked about the grading. Can I say grade 1, 2? What's the grade of chondromalacia patella in this case?
Yeah, I think depending on which classification system he wants to use, did he mention this?
No, I said only grade 2 chondromalacia patella.
Yes, so I think grade 2, depending in, we can just go here into this. I think we have one on school, don't we, where we discuss the cartilage grading. Let me just open that. Cartilage mapping outer bridge. I think we had this here, this diagram, and I think there was some other diagrams where they started to, yeah, so you can see that there are the ICRS classification, which is a bit different, and then I think we had to Leonard posted actually this paper where they compared these different classification systems. I think, was it in this paper, wasn't it, Leonard? Do you remember?
Yep. Yes. You just saw it. You have to go up again.
I remember that, but where's the table? I thought I saw a table.
Yeah, you have to go up.
No.
Just a little bit up. Stop.
Yes. There. Yes, so you can see, so basically ICRS, modified outer bridge, etc. So in your case, when we look at this table, what we can see is a deep partial thickness lesion, basically, where we have a cartilage loss of over 50% of the thickness. So that's what I would describe, deep, over 50% of the thickness. And now it depends on which classification system you use. So, but generally it would be more in the area of 3 rather than 2, unless your surgeon uses this system, which I'm not familiar with. So if anything, I would go with 3. And then if you use this one, you can even subdivide it into these other bits and pieces. So let me just post that in our chat here for your review again. This, I think, is a good article talking about the correlation between, you know, what we can see on MRI and how that matches with arthroscopy, right? So I think it's a good article. Just posted that here, and then we discuss, as you can see, we discuss also the different other systems where you can see grade 3 over 50%, then you can even subdivide into different subtypes, which makes it even more complicated. And this is the typical one, grade 3 outer bridge. Deep defects would be 3. So grade 2 would be basically superficial, but I think in your case, if we go back to the case, and if we assume that's the original cartilage thickness, we can, so let's measure if the surgeon really wants to know a bit, you know, you can here measure different things. So if do you measure the subchondral plate, or don't you measure that? So it's even, you know, even there it starts. So where do you put the marker here? This is where it starts becoming quite confusing. But let's assume 3 millimeters, and then we're going to be down here. This is not just at the end, so we don't want to measure at the very end, because then we have no cartilage anyway. So we measure here, and then we measure something like 1 millimeter. Even if it's just 2 millimeters, it's clearly over 50% down. So I think if you want to give a grading, I would use then grade 3, and you can give like modified outer bridge classification grade 3. So if you use the grading, I would mention which grading system you were using. Otherwise, it's a bit confusing.
Okay, thank you.
Or just call him and ask him, hey, which classification system do you actually want to? Yes, Leonard, please.
Maybe a stupid question, but in the sagittal view, where's for you the FP compartment, and where's the lateral or medial compartment beginning?
Yes, you mean because of the trochlea femoris here?
Yeah.
Yes, I normally when I see a cartilage defect here, I refer it to the patellofemoral, or like the trochlea femoris. So the trochlea femoris for me would be roughly this area, and then this would be more like the, the central portion and the posterior portion. And then in this area, when something is far anterior, it would be the anterior portion of the medial femoral condyle. But this would be normally for me the trochlea femoris, probably up to this point. On an axial,
Okay.
if you go down, then at this location where it switches, this is probably more like the transition point. But you can see the slice thickness in this particular case is quite high, so it goes from here straight down to here, so it's quite a big jump. But somewhere in that area, I would make the cut.
Okay.
Maybe somewhere here. There's probably even like a concrete definition, but that's what I use in daily reporting. So when I assess the cartilage on a coronal, for example, I basically look for this, and then this area here I would refer to the trochlea femoris. So I'm looking for cartilage defects basically where I see the opposing tibia, and then obviously I check on the sagittal just to not miss any cartilage defect at the posterior aspect of the femoral condyle. Yes, Amal, please.
When you measure the cartilage in axial plane, patella, how to differentiate the end of cartilage from the beginning of cortex?
Yeah, so this is not possible on that particular sequence. So we would have to have some other like technique, PD, rather than a true T2, because then you might have a better understanding of what the subchondral plate looks like. But so you can see it here, even like this on the T1, you can measure this easier than on a T2 because the cartilage has this low signal on a T2. But that's why I never measure these things anyways. But the axials, there is maybe something like this would be the plate. But if you include the plate in both measurements, I think just for a rough estimate whether to go over 50 or over 50 or below 50, it's not gonna matter in this particular case. And you have also other like issues, like even like where do you start, here or here? I'm not sure what the correct answer would be. So it's a good question. But yeah, the black chondral plate would not count for the thickness. So if the chondral plate or subchondral plate goes like this, then we would just measure this area here. But even then, we would be below 50% because if there is also like a thick cartilage subchondral plate, then we have even less cartilage.
Okay, thank you very much.
Okay, Maximilian, please.
The publication that Leonard posted on school is explaining exactly this matter in detail. Very good.
Okay. You mean the measurement?
Yeah, the measurement, where it starts cartilage, where it ends the subchondral plate, and stuff like this. Exactly, over 2 pages.
Okay.
Exactly this
Okay,
theme.
lovely. Yeah, so that's a good reminder for us to going back into that article here, and then we can go and have a look. Yeah, so basically, yeah, so stuff like that. So yeah, maybe we can go and have a look at this again and how to measure and all of that. So you can see this also influences, the technique influences how you would measure. Okay, thanks Maximilian for the comment. All right, then let's move on. Let me go to my list. That was Amal's case. So we have Maximilian. So Maximilian, let's go to your case.
Yes, I brought an 80-year-old lady with a minor trauma to the ankle 4 months prior to the MR imaging. And I have a question for you concerning the tibial posterior tendon for a long ago trauma that is way too much signal alteration and thickening and stuff like this around the tendon, and then reaction also above in the bone and some erosion over there. And I was thinking about rheumatoid, something like psoriasis arthritis, or maybe a neoplasm of the tendon sheath. Do you have any hints how to differentiate these? In this tendon sheath, there's surely something going on, like bleeding and stuff like this, but maybe it's an PVNS.
Okay, so this is the PD, so there's no description of the sequences. So this is not,
No,
so there's no contrast, right? So you did not give contrast.
No contrast, intermediate weighted fat suppressed images, and the T1.
Yeah, okay. Okay, so the tendon, let's start on the axial. I think the axial is the best we can see. It's quite a thick tendon, so there's clearly tendinosis underlying all of that and a lot of tenosynovitis. I think all that gray stuff here, that's all the thickened synovium within the tendon sheath. And when you have these chronic, nowadays with 2 months or 4 months even, tenosynovitis, they can make reactive bone marrow edema stuff there. But even that, so we also have the flexor retinaculum partially stripped off, as it looks like from the underlying bone here. You can see the retinaculum kind of like does not really go into the bone. This is the bony surface here. So there might have been like at this injury, some form of stripping injury of the flexor retinaculum, which might, I'm just thinking now out loud while looking at the case, why that might cause some form of a instability also of the tendon, maybe under keeping an inflammation going on, and then that stuff here looks a bit funny. I agree. I would not necessarily think about PVNS necessarily for as a start, but it's a very unusual amount of synovitis. But then thick synovium here, then this part of the flexor retinaculum here, assuming that's the flexor retinaculum here on axial. Yes, you can see it here, kind of like creating an indentation, so maybe some form of like a stenosing tenosynovitis here with a lot of debris or some stuff here in there. I don't see a distinct mass. What would come to mind would be something like gout as a differential. I think that would be in the differential. It's an 80-year-old patient. Okay, and there's no known rheumatoid disease or like inflammatory disease known at this point in her life, right?
No, there's just a minor trauma to the ankle.
Yes,
No,
okay. And
nothing else.
she's 80 years old, and I mean for that the joints look otherwise very good. We see a bit of effusion in the ankle joint, tibial talar joint as well. Maybe just a mild like tendinosis here, maybe a little bit of this. I would not call this plantar fasciitis. Achilles tendon is fine. So, and we don't see any like effusion or like erosion or something along that lines. But did you see the erosion? I'm curious. Oh, this bit here.
It's on the dorsal side of
Yes.
the.
Okay. There, so we can see
There's a small erosion you can see in the axles.
Yes, there's a defect here, and on the axials, this one here. Yes. So this can happen from the synovitis alone. It doesn't necessarily have to be from a rheumatoid disease itself. So I could see how this could have been like issue with the instability, some form of chronic tenosynovitis or stenosing tenosynovitis of this posterior tibial tendon, forming this bunched up synovial tissue here. So what could we do to resolve this in terms of ruling out the mass? We could give contrast, but then it's enhancing, so we're not sure either. Let's see if we find something like stenosing tenosynovitis PTT. Posterior tendon first reported, so we obviously need some images. We want to see. That's not maybe images. Just want to see if we can get something posterior tibial tendon. Tenosynovitis obviously is not specific, but it looks funny and this mass-like appearance. And the thickness of the synovium also would be a good idea to think about something like an inflammatory. But it's funny, if she's 80 years old, never had any issues before, that would be quite unusual because the genes are in her favor. It has kind of like this appearance of something like mechanically, causing an issue here while the tendon slips through all the time and just keeps this inflammation going. That's my idea that I would have here. But let's see if we find something, stenosing tenosynovitis, if we can find something, surgical treatment of stenosing tenosynovitis at the ankle. Yeah, maybe this is a very old article though. Endoscopic posterior tendon sheath. We can check this one. We don't have any MRI images, unfortunately. So what do they say? Stenosing cause posterior middle ankle pain. Well, that's okay. So they just talk about the stenosing, and they don't have. They only have one article, surgical treatment in 1982. I'm not sure if that's a very common entity. I've never set this. So what could we do to establish this? Also, there's a lot of inflammation in the bone. We can also see the partially stripped off fascial sleeve here. These bits here going up here is a little bit lifted off here. And I think so what I would probably do is maybe a dynamic ultrasound. I feel like this would be maybe something to evaluate with ultrasound, also to see whether this is like a really synovium, whether there is just blood vessels in it, and not something like a tophus gout or something. I don't think it's gout. I think it's just a very extensive tenosynovitis, essentially with reactive edema, and and most likely after a stripping injury of the flexor retinaculum in this more posterior aspect, and then maybe instability, and then now causing some form of a stenosing tenosynovitis. I think that's probably what I would go for. Maybe do a dynamic ultrasound or recommend one to see whether you can or she can sublux this. I'm not sure if that's actually going to change much, or maybe then they can try a steroid injection. But yeah, so this looks really very funny case. Okay. Does anybody have another idea? Leonard?
Sadly, no idea. I wanted to ask you if you could show the flexor retinaculum once again.
Yeah, so on the coronals, you can see it coming down. Basically, we have the superficial deltoid band, and then you have the PTT, and what's running over the PTT, the most medial bit, is the flexor retinaculum. It goes to the bone here too, and if you go on an axial, basically what the flexor retinaculum does, it keeps the flexor tendons in place. So it's essentially a structure that also goes through here. It blends in with the fascia and everything, but then it can strip off from the bone here. So you can see this one, this bit goes up here. Here it's still inserting, and then this is the superficial deltoid into the spring, anteromedial spring or supramedial spring ligament complex, and then part of this is the flexor retinaculum. This is PTT, but then the posterior parts of the flexor retinaculum here, they are not nicely attaching to the bone, so they're kind of like lifted off, sometimes creating a pouch where the PTT can dislocate. But essentially, that's the bit where the mechanical problem occurs. Yes, so kind of like a hypertrophic synovium. And I think something inflammatory is not out of the picture, because such thick synovium is frequently seen in, or more seen in, these inflammatory diseases. So I think it's a good idea. And maybe you can even put this into the differential. The erosion could still be just from reactive or chronic synovitis, now 4 months, and the edema is reactive most likely too. And she's 80. I think it depends a little bit on the clinical context, and I would discuss that in the conclusion and give them kind of like these two ideas, favoring more something like a stenosing tenosynovitis.
I'll try to get some clinical information in the follow-up.
Yeah, that's good. Yeah, and there'll be ultrasound, and when they can do some steroid injection, take the inflammation out of this potentially. But yeah, I would leave that obviously to the experts. If the tendon is very thick on tendinopathic, steroid injection, we don't want to get the tendon to tear or pop, right?
Thank you very much.
Okay, so that was that. Thanks, Maximilian. Let me go to my list. So let's go, I think, to Leonard's case. Yes, I think it's your turn, and then Laura. Okay.
Maybe one more question to this case. What do you think about prone positioning for the tendons? I had a surgeon asking for prone position to see what the tendon is like.
Yeah, it's especially good for peroneal tendons. I think for the PTT, it's not really required. It's a big tendon, and partial tears, etc., are more easy to see on the PTT in general. But if it's a specific peroneal tendon question, or even like extended tendons, to be honest, prone position on the tummy, plantar flexed foot in the knee coil, etc., works really well.
Okay. So, okay, my case is a 65-year-old female, and the clinician is suspecting lesion in the anterior horn of the medial meniscus, and it's like a calibration regarding the meniscus. I don't see a tear there, but I want to know if you also see a vertical one in the medial meniscus between junction and body, junction from the posterior horn, with contact to the downer side.
So from the posterior horn to the body,
yeah.
I would not call a vertical tear here. I think
Okay,
these are
because
just some
there's
internal
just
thickness changes.
there
And
are a few dots
say again,
there. One image there. Do you
you mean
think that's real or not?
this one?
Yeah.
Even if I would not call it a vertical tear, I think it's just one single image, and I would be reluctant to call this. And the patient is how old?
65.
65. I would probably not call a distinct tear. I think we just call it a mild substance degeneration here. You could argue maybe there's still one black line going through, and it's just on one slice. It's kind of like it would be more like a hole. And even if it's more like, if you think this would be it, I would call it like a horizontal or oblique tear into the undersurface of the meniscus. That's what I call it. I would not call this necessarily a vertical tear. If it's going like this, I would then only use these things for the real vertical tears.
But you wouldn't say it's a tear with
No, I would not
contact to
call
the...
it tear. I would just say it's a mild substance degeneration at the posterior medial aspect of the meniscus. Maybe there's a tiny ganglion cyst that's here on that single image here. And as you said, no tear at the anterior root of the medial meniscus.
And the same question for the lateral meniscus. On the body, do you see there a horizontal lesion with contact to the upper side? Yes.
So in the body, on the lateral meniscus, let's go over there. So there's a tear here. You can see
that's real, isn't it? Yeah.
That's real, and it's going to be a radial tear. If you can see it like this, and most of the time we should be able to see it here, but we don't necessarily see it now in this particular case. But there is a kind of like a radial, so something like this, and then we can see it. We can see this truncation of this edge here, kind of like a tiny focal radial tear at this free edge of the body. Yes, that's real.
Okay, and another one in the anterior and posterior horn. These vertical lesions are not real, or no, the anterior one is real, or?
Yeah, so I mean, sometimes you can start to see these striations here. There's a lot of degeneration going on in the anterior root with all this cystic change and synovitis and scarring here at this location, the corresponding defects here on the other side of the joint. So I think it's real. Sometimes you can have the same changes without the distinct tears, but I think this one is a real kind of like a little like a scratch on the surface here at the anterior root of this lateral meniscus. Yes. At the posterior one, it's more like degeneration. I don't see like a frank tear. I would not be so sensitive to call stuff like that.
Okay.
Yes.
Yeah, that was my question.
Yes.
How sensitive to be.
Yeah.
And then the ACL, it's just mucoid degeneration,
yes.
Isn't it? Or what would you call it?
Yeah, mucoid degeneration. Especially if there was no trauma, I would just call it mucoid degeneration. Yes.
Thank you.
Also on the axial, and then some ganglion cysts coming out here of this. Okay. Very good. Yeah, so let's go to Laura's case. And where is it? Laura, yes. Let me just copy that into chat. Copy. Tack. Yes, please, Laura.
Okay, so my case is about a 45-year-old woman with a car accident and pain in her right temporomandibular joint.
And that's not quite my specialty, to be honest.
It's about degenerative changes in the temporomandibular joint. Actually, I'm not used to watch this either.
Yes.
But I felt like the condyles had some degeneration. I don't see anything else, and no bone marrow edema or anything else, but maybe.
Yeah. I think I'm probably the wrong person to really give you a good answer here. I'm not reporting these. I've probably reported the last, I don't know, decade ago or something like that. I'm totally not up to this anymore. So I think maybe post it on school, and I'm sure somebody is still seeing a lot of these discs. And then I know this. Did you do functional analysis too with open mouth and closed, and then you can see whether there's a fixed transposition?
With the disc, I don't think there's a problem. It's more about the degeneration of the condyle. But yeah.
So maybe some irregularities here.
Yes, that was my.
Yeah, I can see what you mean, but I don't really. I think I should not comment on this. I don't think that's a qualified answer. But yeah, I mean, there is some irregularity. I can see what you mean, but I wouldn't have the experience to really give you like a good answer. But I'm
Okay.
sure some people in the group have, so feel free to
Okay,
post the
I'll
case,
post.
and I'm sure you will get a good answer there. All right. Yeah, sorry about
Okay.
that. Okay,
Okay.
guys, I think that's it for today. Then I think there is a second question by Nilum. Please post it on school, and we have to discuss it there. And yeah, so just a little reminder: next week we'll skip the session, as you can see in the calendar, and then I will let you know about the updated times. I'm going to send the survey over also to see. So you can see we skipped this one here. I just need to get organized first, and then we'll keep the Friday sessions as they are at the moment, and then we'll get organized for the Tuesday sessions, and I'll keep you updated. Okay, thanks guys, and see you next time. Bye bye.
Thank you. Bye.
Thank you. Bye.
Bye.
Thank you.
Bye.